Hello everyone. In this video, we will talk about the second degree heart block, which is also called the second degree AV nodal block. And if at the end of the video, you think the video is good and informative for you, then please like the video, share the video, and also subscribe the channel. And after that, please press the bell icon to get the latest uploaded video. Thank you once more. So now if we start our discussion about the second degree heart block or the second degree AV block, it has got another name. We call it the mobitz type. Now the second degree heart block is subdivided into two types, type 1 and type 2. Now also known as the mobitz type 1 and mobitz type 2. It was named after the scientist. So what happens in the mobitz type 1? If you compare these two ECG tracings, which I have drawn on the whiteboard, here you see this is the normal tracing where this is a PR interval which is a fixed in duration, and we had seen that the normal PR interval is 3 to 5 small boxes or 0.12 to 0.20 second or one large box. But if you compare this ECG tracing with this one, here you will see a very specific phenomena happening. Now look at this PR interval. This is a normal as the above one. But on the next, you see that PR interval has progress or has increase in its duration. Now, if you compare this one, the third PR interval with the previous two, it's even lengthier than the last two PR intervals. So there seems a progressive PR interval lengthening or progressive increase in the duration of the PR interval, and after third or fourth beat, there will be a missed QRS complex. You see a P wave, but you don't see a QRS complex over there. So this phenomena is known as the Venky Block phenomena, in which what happens that there is a progressive increase in the PR interval, and after third or fourth QRS beat or the QRS complexes, there will be a disappearance of the QRS complex. So you will see PR interval progressively increasing in length, and then you will see a P followed by a P, but no QRS complex here. This is known as mobitz type second degree heart block, and this phenomena is known as the Venky Block phenomena. Now what is actually happening in case of the mobitz type 1? At the level of the AV node or the atrioventricular node, we had seen that impulse will pass through it, will be delayed for a fraction of the second, which will generate the PR interval. Now keep one thing in mind, that P is happening before AV node. The P is because of the atrial depolarization. So the morphology or happening of the P wave has got nothing to do with the AV node. This is the PR interval which is important, or the PR segment which is important. So what had happened in case of the mobitz type 1, AV node lets the first impulse pass through without any interruption. But for the second impulse passing from the atria to the ventricle through the AV node, which is a doorway, it is delaying its transit. And the third impulse which is trying to pass through it is delayed even further. So that is progressively prolonging the PR interval. Now either the third one or the fourth one is denied the entry from the atria towards the ventricle completely. So there will be no impulse transmission across the AV node. Once there is no impulse is transmitted across the AV node, it will not go and stimulate the ventricular muscle to cause the ventricular depolarization, which we see as a QRS complex. So it makes sense that there is a progressive delay of the impulse transmission from the atria to the ventricle through the AV node, and ultimately third or the fourth is denied entry altogether. So that shows us the disappearance of the QRS complexes, but it is flanked by the two P waves, because P wave had happened as a result of the impulse coming from the SA node, not from anywhere else. So atria did respond to the next 2 or 3 impulses coming from the SA node, and they generated the P waves. But yes, that impulse has been denied entry through the AV node going all the way down to the ventricle. So we see disappearance of the QRS complex then. This is not a dangerous diagnosis, but obviously you need to see whether this is because of the electrolyte imbalance or some sort of ischemia is going on. So mobitz type 1 second degree heart block, which is also known as the Venky Block phenomena, is not as dangerous as the next one, which is the mobitz type 2. The second type of the second degree heart block is the mobitz type 2. In contrast with the mobitz type 1, there is no Venky Block phenomena happening. Now this is the tracing of the mobitz type 2 second degree heart block. Rather, there is a very particular event happening, which is that PR interval will stay normal. Now the PR interval is normal, there is no progressive lengthening of the PR interval, but there is a dropped QRS complex and there will be a dropped pulse, because QRS complex or the ventricular systole or depolarization is the one which generates the pulse. So no change in the PR interval, but after either every one normal QRS complex there will be a dropped QRS complex, or after every now and then there will be a drop in the QRS complexes, or there will be no transmission of the impulse across the AV node. If you compare this normal ECG tracing with this mobitz type 2 second degree heart block, which one is dangerous? In type 1, we didn't lose so many QRS complexes, we didn't lose the ventricular systole that frequently as we are losing here. So the heart rate will drop and the blood pressure can drop, patient can become hypotensive or hemodynamically unstable, and that can cause a real problem. There will be hypoperfusion of the vital organs including the brain. Patient can have the syncopal attacks, and this is most of the time happening as a result of the cardiac ischemia or a major problem to the heart and the circulatory system. So this is an important diagnosis. This is a dangerous one, because whatever is happening can cause this problem to slide into the complete heart block. This time around the AV node is behaving very abnormally because there is no PR interval increase, progressive increase, and there is a drop of the beat after every 1 or 2 QRS complexes are normal beats. So there is a difference between mobitz type 1 and mobitz type 2, and in case of, if you should compare this tracing with this normal, here you see a very finely married P with the QRS complex. There is no drop, there is no divorce issue, but here there is some sort of problem going on, some fight, some issue is going on. So this is a normal ECG tracing, and you should compare it with this abnormal ECG tracing of the second degree heart block. So what's happening here, if you see in the mobitz type 2 second degree AV block, AV node is diseased more than it was in mobitz type 1. Why? Because now it is mad enough to stop a lot of impulses which are trying to pass from the atria to the ventricle through this doorway of the AV node. It will let one impulse pass and it will strike down on the next coming impulse passing through it. So it has become a mad person now. It will let one impulse pass through it. It will go and cause the depolarization of the ventricle that will generate a normal fine QRS complex, which is a narrow one. But it will not let the next impulse pass through it. So there will be a P wave because of the atrial depolarization, which has already happened before the impulse was passing through the AV node. But there will be no QRS complex. Why? Because the impulse was not allowed to pass down the bundle branches and the Purkinje fiber to cause the depolarization of the ventricle. So no depolarization of the ventricle, no QRS complex. But again there will be a P wave, there will be a P wave, and between the two P wave there will be a duration and no QRS complex present. And in majority of these patients, they become hemodynamically stable or they can slide into the complete heart block. So these patients require pacemaker or the permanent pacemaker, but obviously if patient is hemodynamically unstable, you need to insert the temporary pacemaker to start with.